Very good morning to respected faculty members and fellow colleagues. I am Dr. Manigandan, final year DM resident, Department of Organ Transplant Anesthesia and Critical Care, and I am going to present my thesis today. It is a comparative evaluation of external oblique intercostal plain block and intrathecal morphine in patients undergoing open donor hepatectomy. It is a randomized control non-inferiority trial. My guide is Dr. Gaurav Sindhwani and co-guides are Dr. Udit, Dr. Anil and Dr. Pamecha sir. I shall be structuring my talk under the following headings. First, a brief background. Living donor hepatectomy presents a unique anesthetic challenge and analgesic challenge. The donor is a healthy volunteer who derives no medical benefit from the operation. Donor hepatectomy involves an extensive right subcostal incision with midline extension. This generates substantial nociceptive input from both somatic and visceral efferents. Acute pain after living donation is severe, and 31% of donors report persistent pain beyond 3 months. Selecting an appropriate analgesic technique for this population requires careful balancing of efficacy, safety, and ease of administration. Poorly controlled pain can result in various complications in the donor, including respiratory, which includes impaired deep breathing and coughing, leading to atelectasis and pneumonia due to inability to clear the secretions. It can also affect the donor recovery by causing ileus, chances of venous stasis and thromboembolism, delayed mobilization, thereby prolonging the hospital stay. It can also affect the donor psychologically by causing distress and dissatisfaction and overall negative perception about the donor experience. Till 2022, before the ERAS protocols came in, thoracic epidural analgesia was considered the historic gold standard. But after 2022, the ERAS Society guidelines no longer recommended the routine thoracic epidural analgesia, and they had shifted towards intrathecal opioids like morphine or wound infusion catheters as alternatives. Coming to the current neuraxial gold standard, it is the intrathecal morphine. Morphine is a highly hydrophilic, and the vascular reabsorption from the intrathecal space is very slow, allowing extensive rostral spread within the CSF after injection. A single dose therefore produces both segmental and supraspinal analgesia lasting about 24 to 48 hours. It is very technically simple, a single injection with a failure rate as low as 1%. Incorporated into ERAS-based perioperative protocols for hepatobiliary surgery. The dose-related adverse effects but are significant, including nausea and vomiting in the postoperative period, pruritus about 60%, urinary retention, and a risk of delayed respiratory depression in about 2% of the donors. In the recent time, there has been a paradigm shift away from the central neuraxial blocks like the epidural or the intrathecal morphine towards superficial facial plane blocks. This is mainly due to the avoidance of dural puncture in these patients. Many donors are skeptical to receive injection in their back, and the coagulation risks inherent to neuraxial techniques. Wider availability of higher resolution ultrasound machines inside the operation theater, and absence of neuraxial opioid related side effects and sympathetic blocks like hypotension. Numerous abdominal wall blocks have been studied in the population for covering the subcostal donor incision, like subcostal tap block, quadratus lumborum block, and erector spinae block. But these blocks do not extensively cover the dermatomes required for producing analgesia in a donor incision. These are the limitations of these blocks. Some of these blocks are very deep, and the needle has to traverse a very longer path, involving the vascular structures in between. The recently evolved addition to this facial plane blocks is the external oblique intercostal plane block. It was first described by Elsher-Kavi in 2021. The block is actually a very superficial block. If we could understand the anatomy from this block, after retracting the skin and the subcutaneous tissues, we can come across the external oblique muscle in the anterior and lateral wall of the chest wall. Between the external oblique muscle and the intercostal muscles, we can see the branches of the anterior and lateral cutaneous nerves from T6 to T10 traversing in this plane. Our main target is to block the nerves in this plane. So this is the cross-sectional anatomy showing the skin, subcutaneous tissues, the ribs, 6th rib and the 7th rib, the external oblique muscle, the intercostal muscles. The nerve fibers run in this plane, and our target is to block the nerve fibers in this plane. Coming to a brief review of literature about this efficacy of the EOI block, many studies have been done comparing this EOI block with other facial plane blocks like the subcostal tap block or with a normal saline comparator or IV-PCA. Administration of EOI block has significantly reduced the 24-hour opioid consumption in the subset of patients. As such, there are no studies comparing EOI block and our target of interest, that is the intrathecal morphine, in donor population. Coming to review of literature about a facial plane block versus intrathecal morphine, some studies have been done in donor population in a single center from South Korea, and they have compared, initially they have compared a bilateral single injection of erector spinae plane block with intrathecal morphine. Then they adapted and found that it was not giving significant results, and they modified the technique by giving a bilateral continuous erector spinae plane block and comparing it with intrathecal morphine of 400 micrograms. They found that both the techniques resulted in no statistically significant difference analgesia between both the techniques. My trial is actually a fourth in the sequence of trial that have been done in our institute in the donor hepatectomy. Initial trials focused on comparing the historic gold standard thoracic epidural analgesia with intrathecal morphine. Then we did a study comparing different doses of intrathecal morphine like 200, 300 and 400, and we found that 300 micrograms of morphine is a safe and it can be given for all population. Rachna et al. Did a plenary presentation in the recent ILTS conference, and they have demonstrated EOI block versus thoracic epidural analgesia, and they found that both the techniques are comparable with respect to fentanyl consumption. My present trial is the remaining and previously untested comparison, comparing EOI block versus intrathecal morphine, which is the current Neuraxel gold standard, at a dose of 300 microgram. So the gap in evidence and the research question. Gap in the literature. To the best of our knowledge, no randomized trial has compared the EOI block with intrathecal morphine in open donor hepatectomy or in any surgical population. So the research question is, in adults undergoing open living donor hepatectomy, does a continuous bilateral EOI block provide postoperative analgesia that is not worse than single shot intrathecal morphine of 300 micrograms? The hypothesis is that continuous bilateral EOI block is non-inferior to intrathecal morphine with respect to 24-hour fentanyl consumption with a pre-specified margin of 100 micrograms. Aims and objectives. Primary objective: to determine whether bilateral continuous external oblique intercostal plane block is non-inferior to single-shot intrathecal morphine with respect to cumulative intravenous fentanyl consumption during the first 24 hours after open living donor hepatectomy. My secondary objectives included total fentanyl consumption at 48 hours, numerical rating score which is used to assess pain. It was assessed at both rest and on movement, time to first rescue analgesia with both the techniques, incidence of referred shoulder pain, and looking for complications like nausea, vomiting, pruritus, and respiratory depression. And sedation score was assessed at these time points. Materials and methods. It was a single center, prospective, open label, parallel group, randomized non-inferiority trial done in our Department of Anesthesiology and Critical Care. IEC approval and CTRA registration was done, and it followed concert guidelines. Written informed consent was obtained from all participants before their enrollment. Eligibility criteria. Inclusion criteria included healthy donors aged between 18 to 60 years, scheduled for open living donor hepatectomy, elective surgeries, and willing and able to give informed written consent. Exclusion criteria included patient refusal, contraindication to neuraxial anesthesia, known allergy to local anesthetics, inability to comprehend the use of IV patient-controlled analgesia, and local skin lesions at the planned block or lumbar puncture site. Randomization. A computer-generated random sequence number was used with a block randomization method and a block size of 6. 1:1 allocation ratio was followed. Allocation concealment was done using the SNOS technique, opened only after written consent and immediately before the intervention. Groups. EOI group, total study population was 60, sample size was 60, and both the groups, 30 donors were allocated to both the groups. Blinding was not possible because of the nature of intervention. However, the primary outcome was fentanyl consumption, which was read directly from the IV PCA device. It is an objective machine-recorded variable that is not susceptible to observer bias. Sample size was calculated using following pooled standard deviation of 140 micrograms, which was obtained from our previous study, and a non-inferiority margin of 100 and a one-sided alpha of 0.05. We found a total sample size of 60 was required, and we split it as into 30 per group. Next, coming to the intervention, in the EOI block group, it was performed after the induction of general anesthesia, with the patient in supine position and using a high frequency linear ultrasound. The probe was placed in the space between the mid-axillary line and the anterior mid-clavicular line and anterior axillary line at the level of 6th and 7th rib, to identify the following structures like the skin, subcutaneous tissue, external oblique muscle, and the intercostal muscles with the pleura between. Both the sixth rib and the seventh ribs were identified. An 18 gauge 2-inch needle, which is used for epidural, was brought in plane from cranial to caudal direction and positioned in the space between the sixth rib and the seventh rib, between the external oblique intercostal muscle and the external oblique muscle and the intercostal muscles. A 20 ml bolus of 0.25% levobupivacaine was injected in this space to separate the external oblique muscle above from the intercostal muscles below. Then a tunneled catheter was placed in the space and a local anesthetic infusion of 5 ml of 0.125% levobupivacaine was started inside the catheter, and it was continued for post 48 hours in the postoperative period. Coming to the comparator arm, which is the intrathecal morphine group, it was performed before induction of general anesthesia with the patient in sitting position. Skin was infiltrated with local anesthetic and dural puncture was done at L3, L4 space with a 25 gauge Quincke's needle. After a free flow of cerebrospinal fluid, about 1 ml of 0.5% AV bupivacaine and 300 micrograms of preservative-free morphine was administered. Here, no catheter was placed. This is the image showing the technique of administration of intrathecal morphine. In both the groups, standardized anesthetic protocol was done as per institutional standards, and all the surgery was done by the same surgical team with right subcostal incision with midline extension. 30 minutes before extubation, intravenous ondansetron was given and all patients received paracetamol 500 mg. Reversal was done with neostigmine and glycopyrrolate, and extubation was done once standard criteria were met and the donors were transferred to the recovery. Coming to the postoperative analgesia protocol, all donors received the same postoperative analgesia protocol. It was standardized for all donors. All the donors were started with IV patient-controlled analgesia using the drug fentanyl at a concentration of 10 mics per ml with a bolus of 2.5 ml per dose, lockout of 15 minutes, maximum doses set at 4 doses per hour, and no background infusion. The IV PCA was continued for 48 hours in the postoperative period. All patients received intravenous paracetamol 500 mg every 6th hourly, and intravenous fentanyl 25 mics bolus was given by attending nurse above and over the PCA if the patient reported a numerical rating score of more than or equal to 4, and rescue doses were included in the total fentanyl consumption. All patients received ondansetron 4 mg, and if nausea was still persistent, they received dexamethasone. Respiratory depression was defined as a respiratory rate of less than 8 per minute, or carbon dioxide retention more than 50, or a modified Ramsay sedation score of more than 4, and it was treated with naloxone 100 to 200 mics IV. Monitoring, all patients were monitored in the postoperative period with hourly respiratory rate and sedation scoring throughout the first 48 hours. Yes. Spinal anesthesia, sir. Dose, we have done already a study in our institute, sir. We have compared 3 different doses of 200, 300 and 400 mics. And we found that 300 mics is offering better analgesia with lesser side effects, sir. So we have chosen 300 mics as empirical. The peak action will last between 18 to 24 hours, sir. So 2 days, sir. Yes, sir, but the effect will taper between the next 24 hours to 48 hours, sir. So we have used both the techniques. Yes. 24 hours peak effect will be there, sir, but analgesia will be sustained over the remaining times. Outcome assessment, the outcomes were assessed at the following time points and recorded at every time point. Numerical resting score at rest and on movement was assessed. Modified Ramsay sedation score and respiratory rate. Referred shoulder pain recorded as present or absent. Nausea, vomiting and pruritus. The following parameters were recorded once, that is fentanyl consumption at 24 hours and 48 hours, read directly from the PCA device, and time to first patient activation of the IV patient-controlled analgesia. Statistical analysis, normal distributed variables were assessed using the independent t-test and non-normally distributed with Mann-Whitney's test. Categorical variables were compared using the chi-square test. SPSS 31 was used and p-value of less than 0.05 was considered statistically significant. Non-inferiority was concluded if the upper limit of the 95% confidence interval lay below the 100 microgram margin. Coming to the CONCERT flow diagram, 62 patients were assessed for eligibility and 2 donors were excluded because one declined to participate and one had history of intervertebral disc prolapse. 60 donors were randomized with 30 in each group, EOI group also 30 and intrathecal morphine also group 30, and all the donors were followed up. No one was lost to analysis and all the donors were analyzed. Coming to the results, seeing the baseline and intraoperative characteristics, all donors were matched in terms of their baseline and intraoperative characteristics. No statistically significant value or difference was found with respect to the baseline and intraoperative characteristics. Coming to the primary outcome, which is the 24-hour fentanyl consumption, in the EOI group, the 24-hour fentanyl consumption was 225 mics plus or minus 62 microgram, and in the intrathecal morphine group, it was 152 mics plus or minus 31 micrograms. The mean difference between both the groups were 69.17 microgram. The 95% confidence interval was between 44 to 94 micrograms, and the p-value was statistically significant. The upper limit of the 95% confidence interval, that is 94.26, lay well below the pre-specified non-inferiority margin of 100 micrograms. This is the forest plot depicting the primary outcome, that is the 24-hour fentanyl consumption, and the non-inferiority, the 24-hour fentanyl consumption with the mean difference and the 95% confidence interval lay well below the 100 micrograms of non-inferiority margin. Yes. Significant, sir, but non-inferiority wise, it is just 3 additional doses, sir. Additional just 3 doses, ma'am. Each dose is only 25 mics, sir. So it's sadly 33 doses.
We have taken 100 microgram of difference to be as a clinically non-significant difference. Although the statistically this value would be different, but clinically we are justifying that over a 24-hour period, this patient has consumed only 4 doses more when compared to a patient of an intrathecal morphine. And with respect to the complication which he is going to tell, based on that, we are trying to justify that this technique could be an alternative, although it is consuming 100 microgram fentanyl more when compared to the intrathecal.
Because this is a wonderful study. Your technique is also very innovative. But based on the trial which we've already done, first thing. Second thing is the way we have calculated the sample size is just 30. And in this 30 sample size also, you're reaching almost close to significance. So if you increase the sample size, the difference will become significant. Then the question will come, because you yourself have done a study previously, how did you not calculate a sample size and just took the 30 margin, because you're doing a large number of liver transplants also? So
our sample size was based on our
Ma'am, sample size we had assumed 24 hour. It was taken from our previous study only, wherein we compared, we found that the standard deviation using intrathecal morphine of 300 micrograms was 140 micrograms. Ma'am. Using that standard deviation and a non-inferiority margin, we have taken it as 100 mics, which is hardly 3 to 4 doses, and we have calculated sample size based on that to achieve 80% power, ma'am, for the primary outcome of 24-hour fentanyl consumption.
Minimum sample size which is required for an RCT. So it's not like a good sample size calculation. We should have taken more patients. And why I'm saying this, because see, when you are saying something and which is a very small sample size, and this is the difference. Any critique will say this technique is inferior. Inferior, we are just saying non-inferior, but if we reach that 60, supposing 60, 30 more patients, it will become very inferior. So then we have to have some strength in saying, what are the other unique things, maybe not based on fentanyl, maybe something else is more important there.
How much money is required for both the procedures? How much is the cost effectiveness in terms of money?
Cost-wise for the block.
Let them complete, please, sorry to.
Yes.
I interrupted, so.
Coming to the 48 hours, 48 hours consumption, fentanyl consumption, the mean 48-hour fentanyl consumption was 468 microgram in the EOI group and 333 microgram in the intrathecal morphine group. Mean difference of 135 mics, and it was also statistically significant. Coming to the next objective, our secondary objectives like the pain scores, numerical resting scores at rest and on movement. Numerical resting scores were statistically indistinguishable between both the groups at every one of the 7 assessment points, both at rest and movement. Coming to adverse effects, nausea and vomiting, the incidence of nausea and vomiting was 40% in the intrathecal morphine group, but it was only 13.3% in the external oblique intercostal plane block group, and it was very much statistically significant with a p-value of 0.02%. It shows that significantly more nausea and vomiting occurred with the intrathecal morphine group. Next, coming to one of the commonly recognized side effects of intrathecal morphine, which is pruritus. The incidence of pruritus was 8% in the EOI group and 26.7% in the EOI group and 60% in the intrathecal morphine group. It was also statistically significant with a p-value of 0.009. Time to first rescue analgesia. The time to first rescue analgesia was significantly longer in the intrathecal morphine group than in the EOI group, with a mean difference of 25 minutes with a p-value of 0.002. Coming to referred shoulder pain, which was assessed as at both rest and on movement, and it was asked as a leading questionnaire to the donors. The incidence of shoulder pain was more with the EOI group than in the intrathecal morphine group at both rest and on movement, and it was statistically significant. Using the for assessing the complications like sedation, respiratory rate, and carbon dioxide retention, modified Ramsay sedation score was assessed, and both the groups were comparable at all points for sedation. So this is the overall summary of the results, and the primary outcome met the non-inferiority. Moving on to the discussion, that is the primary outcome for non-inferiority. The upper limit of the 95% confidence interval was well below the pre-specified margin. Continuous bilateral EOI block is therefore non-inferior to intrathecal morphine with regards to fentanyl consumption in the first 24 hours. Roughly 3 additional 25 microgram PCA demand doses over the 25 hours was about 6.9 milligram of IV morphine equivalent. The NRS did not differ at any of the 7 time points between both the groups. Comparing it with the existing literature, Kang et al. In 2019 used a single shot technique of erector spinae plane block and compared it with intrathecal morphine of 400 micrograms. And they used another parameter like numerical resting score for testing, and they found that it was not inferior and non-inferiority was not met. The same Kang et al. In 2021 modified the technique. They used a bilateral continuous erector spinae plane block and compared it with intrathecal morphine, and they found that both the techniques achieved similar opioid consumption in the 48 hours. Our present trial, which is done in open living donors, all these surgeries were done in laparoscopic donors, and our trial was done in open living donor, and a bilateral continuous EOI technique was compared against a neuraxial standard of intrathecal morphine, and we found that non-inferiority was met. Next, coming to the adverse effects profile, nausea and vomiting, it was statistically significantly less in the EOI group. This is because the rostral CSF spread of the intrathecal morphine to the area prostrema triggers the chemoreceptor trigger zone, which lies outside the blood-brain barrier. This results in mu opioid receptor activation, triggering nausea and vomiting. Nausea and vomiting can have severe psychological distress to the donor, hampering their food intake, oral intake, and quality of recovery. Our findings align with the study done by Kang et al. In laparoscopic donors, where they found that the incidence of nausea and vomiting was 86.2% in the intrathecal morphine group and 30% in the group that received the erector spinae block. Coming to the next side effect, that is pruritus, morphine directly reaches the medullary dorsal lawn of the spinal cord and activates the trigeminal nucleus by CSF spread. It also activates the mu receptors, and it causes a dose dependent, and it is reproduced in every comparison. Kang et al. Showed significantly lower pruritus with ESP at 8 hours and 24 hours when compared with intrathecal morphine. The incidence of pruritus was 86% using intrathecal morphine, whereas it was only 3 to 4% in the patient that received the group block. Lee et al. In 2022 in a hepatectomy surgery showed that pruritus occurred only in 3.7% of the patients receiving a quadratus lumborum block, whereas it occurred in 90% of the patients receiving intrathecal morphine. Coming to referred shoulder pain, this is the main thing where the ITM reaches the pathway, whereas the EOI cannot. Retraction and right lobe mobilization will irritate the diaphragm. The afferents of the phrenic nerve, that is C3 to C5, run in this plane. This causes shoulder pain, and it is generated at the level of the cervical cords. The EOI block covers only the anterior and lateral cutaneous nerves of T6 to T10, and C3 to C5 lies well beyond the reach of any chest wall block. It is not only for EOI, but none of the chest wall blocks can reach the C3 to C5 dermatomes. Morphine is hydrophilic, slowly absorbed from the CSF, and spreads rostrally to the cervical and supraspinal mu receptors. Yang et al. In 2022 have studied 218 hepatectomies and showed that the incidence of shoulder pain is 41.1%, which aligns with our study. Saini et al. From our own institute have done 60 open donors comparing thoracic epidural analgesia with intrathecal morphine, and they found that the NRS scores was less with intrathecal morphine than with thoracic epidural analgesia at 12 hours. Next, moving on to time to first rescue analgesia, it was significantly longer in the group that received the intrathecal morphine because intrathecal morphine was given before induction, and morphine's peak CSF effect coincides with emergence and persistent for 18 to 24 hours. The EOI bolus was given after induction, and 6 hours later at emergence, only the infusion is going on. An infusion sustains a plateau but does not create a peak. Corning et al. In 2020 showed that intrathecal hydrophilic opioids consistently prolonged the time to first rescue analgesic. Against its true peer, like a subcostal tab block, the EOI block performs well, and the first patient-controlled analgesia activation was significantly longer in EOI group when compared to subcostal tab block. Moving on to the clinical implications, fewer opioid-related side effects were found in the group that received the block. There was significantly less vomiting, nausea, and pruritus, which can significantly affect the donor recovery in the post-operative period and their quality of life. The cost was only additional 3 to 4 bolus doses in the IV-PCA. And the catheter permits repeated bolus or continuous infusion tailored to the individual donor. Strengths of the study, to our knowledge, this is the first randomized control trial comparing intrathecal morphine directly with a continuous bilateral external oblique intercostal plane block in open living donor appendectomy. And it is the first randomized comparison of a EOI block against a neuraxial opioid in any surgical population. The non-inferiority margin was anchored in the standard deviation observed in our own previously published study in the identical population and operation. Limitations, the nature of the intervention prevented blinding. It was an open label, but however, bias of fentanyl consumption was removed using an IV-PCA, which was objectively recorded. We did not measure the quality of recovery using a validated instrument, such as quality of recovery scale. And shoulder pain was assessed using a leading question, which is yes or no, and it can be an overestimate. The incidence of PDPH was not assessed. Conclusion, continuous bilateral external oblique intercostal plane block provided post-operative analgesia that was non-inferior to single-shot intrathecal morphine with respect to 24-hour fentanyl consumption. The EOI block had a better side effect profile in terms of less nausea, vomiting, and pruritus, while the ITM group had lesser shoulder pain and prolonged duration to first rescue analgesia. So we can conclude that continuous bilateral EOI block is a safe, practical, and clinically acceptable alternative to intrathecal morphine for post-operative analgesia after open living donor appendectomy. I'd like to thank my guide, Dr. Gaurav sir, Department of Anesthesiology, Department of HBB Surgery and Transplant, and all the donors who consented to take part. Thank you.
I might have missed. Did you show the pain scores for the?
Yes, sir.
Show one more time.
Pain scores at rest and on movement, sir, at various time points.
Time the pain starts and what time you gave the injection?
Actually, it was activated by the patient, sir. Whenever the patient felt pain, they could press the device. It is an automated device which is done by the patient only, sir.
The pain score remains high from 24 to 48 hours.
Yes, sir.
So there is no pain relief.
No, sir. The patient will activate the PCA device whenever he has pain.
For this, correct me, I may not be understanding what you are showing, but if your pain score on the y-axis is this, so the patient is in continuous pain for what, 24 hours?
No, sir. After that, they will. If the pain score is only above 4,
24 to 48 hours.
yes, sir. More than 4 is the threshold, ma'am. So none of the patients had pain score more than 4.
Acceptable pain based on the subjective score is a score of up to 3. If the score is going beyond 3, then it is considered as a non-acceptable pain, and then the intervention is suggested. That is what we always tell the patients also, that if the pain is more than 30% or more than 3 based on this score, then you should press that button to take that button.
Is the patient able to score the pain himself?
Yes, we tell them pre-operatively, properly give them the score and tell them score of 1 to 10, where 1 is the minimum, then not be taking fentanyl for all the pains. This opens new areas for doing this for other surgeries also. That's a good thing. But sample size could have been better and if you can still continue.
I think we require a little larger sample.
But what
There
I
are
can,
other things that we need to consider here, except apart from this, the expertise that you have may not be cannot be generalized to
because to
other.
reach to this topic now,
And the invasivity of the procedure also has to be kept. in
it
mind.
took us almost
I'm
now 5,
asking
6 to
for-
7 years to come to this topic. Because initially we started as he was in 2017, 18, we started off with the epidural. Then we shifted to the intrathecal morphine. Then further now we are shifting to the facial plane blocks. We are finding that these plane blocks, they are clinically, they are almost equal to the intrathecal morphine and the other neuroaxial techniques. One thing which we have missed, I think, in this study, and we can still take out the data, is the effect of these post-op complications. Whether these post-op complications are leading to the increased duration of the hospital stay for the patient. If we can take out that data, and if that data, because nausea, vomiting, and pruritus, they're very severe complications for the patient, and it can lead to the delayed discharge. So if we can retrieve that data, and if we found it significant, based on that, again, we can say that.
We also takes. Also have lectures. And the ASP will have. Cost analysis also.
Cost-wise, it was similar.
Cost analysis. Also.
It's when we are discussing about the dose of fentanyl, should we not put also the per body weight, means microgram per kg or something?
Yes.
Because each one will have its own requirements, so proportion of patients and the pain is a subjective this thing for the patient. So each patient will have his own threshold. So how do we take into control these factors when we are assessing these drugs?
So ma'am, because it's a donor population,
Ma'am, as you said, pain is subjective, and we have counseled the patient that unless they have severe pain, they shouldn't activate the IV PCA device. But we can try to do it as microgram per kg dosing also to assess the individual requirements.
the main thing, the donor population, all these variables, they are very much under control. So that's why we decided on one particular dose. That is the ideal thing to do per body weight, because since their body weight is in a range of 60 to 70, I think, for the donor. So based
My
on that,
other suggestion was, even if you do not take into account the surgical thing, because again, donors do not have too much, maybe some may be having, but that should have been an exclusion criteria. If somebody has a surgical or prolonged something. The second thing was just to add the duration of your ICU, or means time to recovery, very quick. That is also a very important parameter which will affect all these means as an outcome measure of such things.
Yeah.
I think so.
he can go back and he
Go
can
back
take out
on
that
this.
data.
Thank you, sir. Thank you. Thank you. Thank you. Thank you.
Okay.